Hello there. It's Dr. Verlage again, here with our next topic. This month's topic is going to be about screening with sensitivity, identifying maternal mental health and substance use disorders. So, obviously, knowing the tools we have to screen for things is important. But I think more interesting for us to talk about and discuss is our approaches to it and the language we use and how we discuss these things with patients. So let's move in. One of the more widely used screener tests that we have, which I've brought up in previous presentations, is the EPDS, which is the Edinburgh Postnatal Depression Scale. It's the most commonly used in OB family medicine offices for women in the peripartum period. So while it was designed for women in the postpartum period, we do have data that it is also sensitive to detecting depression in women during pregnancy. So it is the one that most that is just used at intervals throughout pregnancy and then postpartum for up to a year. So what's the difference? So you probably are familiar with the PHQ-9, which is the most commonly used depression scale for, say, the adult population in different mental health settings. You can imagine that some of the DSM criteria for depression, what is the DSM? That's our manual for how we have criteria for different diagnoses. And in those criteria, there's certain questions that may shift during pregnancy and postpartum. And so the Edinburgh scale kind of takes that into account in phrasing of its questions compared to the standard PHQ-9s, which goes off of that DSM criteria. Specifically, the postnatal scale or the Edinburgh scale doesn't ask about appetite, which is a criteria for depression. It can go up or down, but you can imagine that is often affected in pregnancy and postpartum, so may not be as accurate for helping us understand if it's a part of depression, a depressive episode. So it'll say exclude that. The phrasing for like the sleep question. So in our criteria, somebody may be sleeping more or less than they normally would during a depressive episode. And again, something that could easily be affected in pregnancy and postpartum from biological reasons and not psychiatric ones. So I think the phrasing that they have in the Edinburgh scale is something like, I haven't been able to fall asleep because of feelings of guilt, something to that effect. So making the sleep issue specific to some kind of psychiatric process, helps us, make it more specific to the population and other kind of nuances like that. They do include a couple of questions for to screen for anxiety also, but as you'll see in the next slide, it's not as sensitive for that. But something is better than nothing, and you can imagine the more questionnaires you have somebody fill out, the more either they'll not be able to answer them accurately or clinics aren't going to use as many of the scales if you kind of over ask. So it is helpful to have some anxiety questions in it, but if possible, better to have something that has some more sensitivity to detecting specific issues, which brings us to the next one. There's also the PASS, or the Perinatal Anxiety Screening Scale. So this one is designed specifically to screen for a broad range of anxiety symptoms during pregnancy and postpartum. It was able to identify in a study 68% of women who already had a diagnosed anxiety disorder compared to when you see that EPDS3A, those are referring to the 3 anxiety questions in the Edinburgh scale, which was only able to detect 36% of them. So again, maybe why, if we can administer this test, it's helpful. I think just talking to women who are experiencing symptoms postpartum, it is it's much more common to talk about, be aware of postpartum depression, but postpartum anxiety is, very common and not as, say, watched for. So again, utilizing these, and so some women might think that it's normal to overcheck their baby, constantly not be able to sleep because they're worried, all of these things, and not, be on the lookout for postpartum anxiety as much as depression. So again, if we can utilize this scale that obviously is much more effective to detect those things, could be very helpful to include when we're talking to women postpartum or during pregnancy and postpartum. You can use the GAD-7. GAD-7 is the questionnaire we used, or the screener test we use for, say, the general mental health population. It didn't perform as well as we would want to for a screener test in a specific study that was looking at women in the peripartum period. So, if you can, use the PASS, it seems to be a better alternative. But if not able to, GAD-7 is better than nothing. This was interesting, which I wasn't even aware of before I was creating this presentation, is that there is a scale to look at PTSD specific to childbirth as a screener. So in my kind of clinical view, for something to be qualified as traumatic, that is something that could induce, say, PTSD from happening, somebody has to have either their life or a loved one's life in serious risk of harm, or death, and having very little to no control of the situation. So during childbirth, the algorithm of outcomes is very many. And I think most women walk into it with a certain expectation of how things will go, and it very often does not follow that. And when it doesn't, it can be very scary. They can feel like something's going to happen to their baby many times. They can feel like their own life is at risk. So many childbirth experiences, in my mind, could easily meet criteria for a traumatic event, which is kind of maybe why they identified this as something that might be, specifically screened for in the context of the childbirth experience being traumatic. So I'm excited to hear that they've come up with something. Now, when I was reading more about this scale that they came up with, the City Birth Trauma Scale, I read that it's a 29-item questionnaire. That is a little on the long side. And again, the longer you make it, the harder it is to apply it and actually use it. I think part of that problem is that the criteria for PTSD is so complicated. If you go to the DSM, it's pages, of all these subsections and subsymptoms. And so it can be a little bit of a maze. So how much do we use that versus more of kind of a clinical discussion? Hopefully anxiety symptoms, some kind of anxiety questionnaire screener would lead the person to actually get interviewed for us to screen for PTSD, or to actually in a clinical interview explore the possibility of PTSD. With how complicated we've made a PTSD diagnosis from our criteria, it makes sense that it's going to be tough to come up with a screener test. So, but hey, here's for having something at least, and that people are thinking about this. Okay. For substance use screeners, there is not one specifically for the peripartum period, but of all of the ones that say you can find on the NIH website, the TAPS, and this is the one that Frontier Psychiatry uses, but the TAPS seems to be the one that's best for adults and screening for multiple substances. And that's kind of one of the benefits of it, is that it screens for tobacco, alcohol, prescription, and illicit substances all together in one, so we're not adding more, screeners to the list. So that's probably the best one that we could use for the peripartum period. Some things that are nice about it, it again combines everything, but it also has like a pre-screen. So, if it has 2 sections. So if in the first section you test negative, then you don't need to fill out the second section. If you test positive, then they're going to ask more specific questions. So minimizing the time for, say, patients who are not using substances, hence it's less lengthy, is a nice component to it. And it's looking at substance use over the past 12 months. So on the very dry side of things, those are the different, say, screener tools we have. I would recommend, sure, there's lots out there, but for the ones that we would be thinking about for the peripartum population. I think this is a good place for me to for us to sit down and think about the whole screening process and the different challenges that come with that. So this will be a lot of me just sharing stories and maybe shifts in my perspective and training of how to really understand different problems, populations, and how to approach them to make sure patients are getting what they need from us. So for substance use disorders, here I was starting out psychiatry, what I believed with an open mind about it as a disease, but definitely having moments where I recognize my own internal biases. You guys are aware, or maybe aware, that Suboxone, it's a medication we use to treat opioid use disorder, and you used to have to get this special license to prescribe it. That's no longer the case. But back in residency, they made us go to this 2-day training. And so people who were there were us, we had to be there, but also primary care doctors, OBs, and others who were specifically seeking this treatment out, or seeking this training out to provide treatment for people with substance use disorder. So already kind of selecting for people interested in helping this population, which you would inherently think that it would mean that they would be on the more open-minded side of things, which I think is true. And again, I just used to reflect how we really need to keep our own biases in check. So as this addiction psychiatrist was giving the presentation, he was asking, okay, so let's say you have somebody who uses opioids and they're on Suboxone and they do the urine drug screen and they come out positive for opioids. What do you do? And so there's like a questionnaire, and most people were talking about, well, you dismiss them from the clinic. They didn't, follow the preset expectations of treatment, which is you're not going to be using opioids when you're on this medicine. And again, for me, this was a huge shift when I watched these people say that on some level I kind of agreed. And the addiction psychiatrist made us all pause and explained, if we get this person just one day that they use half as much of the drugs that they normally do, that is a half a day that they get back, that they can engage with their family, that they can, get the resources they need to survive, that they can figure out their housing. That is a positive move for their treatment. So it is not black and white, you're sober or you're not sober, right? So if they've used, we have to see them more regularly. We have to figure out what we can do to get them sober again. But it is not, they should in no way be dismissed from the clinic. It just means that they need more help at that time. And so to think that here we were all thinking like, oh, well, I guess that, we can't have them in the clinic, and that's where we were all that's where our minds were at, was so far off of the truth of no, any improvement is good. That helps. And we are the only people here who are going to be able to help them. So it's kind of like if you compare it to diabetes. Someone is on these medicines, or any disease. They're on these medicines. It's not working as well as we need it to. Do we just say, well, I guess that didn't work. Good luck? Absolutely not. We treat the disease. We say, okay, this disease is getting worse. What's our next step? What's our next move? We need to see you more often, right? So us really recognizing that and communicating that to patients. So, this same psychiatrist who, was just absolutely wonderful. His name was Dr. Waklu. But I remember with a patient who we'd followed for a long time, been sober for 18 years. And he had him do a drug screen. And he said, Doc, you don't trust me? I've been sober for 18 years. He said, I trust you. I don't trust your addiction. So whenever I talk to patients, I sometimes separate themselves from the addiction, themselves from the disease, right? It is not, say, a character flaw. It is not a moral shortcoming. It is a disease that we are treating together, that we are figuring out together. So, I think especially for women who are pregnant and postpartum, I can't imagine how vulnerable it would be to be struggling with the disease that is addiction and having to talk about it with somebody. So us repeating that this disease is terrible, talking about it as a disease, talking about what can we do to help it, even if they're using, what can we do to make that just a little bit less? That is a good thing, and even if they're not ready to stop using, staying engaged with them, meeting them where they're at, staying in the loop so that if and when they're ready, you guys have everything set up. All of that is so meaningful. So, when we're screening for this, and when we're talking about this with patients, we need to overemphasize these points so that they feel comfortable communicating back to us, telling us that they are using, feeling comfortable with telling us how much they're using. I think that's a really important thing that I always need to check myself in about when I'm talking to patients. And again, I try to be really mindful about talking about and communicating to patients. This kind of ties in with kind of the next similar point, which is, pregnant women, when we're talking to them, need to feel supported, need to feel that we support them and are there for them. When, I can make my recommendations, hey, I'm seeing this. I would say, let's start a medication. Here are the pros and cons. But I always say, this is your body. This is your choice. I'm going to be here to help you in whatever way that I can. So if they choose something that maybe I didn't recommend, I say, let's do that. Let's keep visiting. Let's keep talking, right? And I will be here. And, you need to feel supported as a mom through this time period. I'm just here to share knowledge. You're going to make that decision of what's right for you. And just know that I'm here in your best interest in whatever form that means. So, there's so many reasons why someone might be hesitant to engage with mental health treatment, especially medication. So even if it means me visiting with them every month to just talk about where they're at, to answer questions, to think about things from different perspectives and walk through them with that, I would much rather have that rapport and have them returning to come talk to me so that if and when they're ready, we can move in with the medication if it's indicated. I think that we can, a lot of times, keep our biases in check. I'm sure that everybody watching this is probably going to be pretty good at that. But patients don't sometimes know that, right? So we have to be very mindful about telling them, hey, this is not about me. This is about you. I care about you, and this is what I know, and these are our options, and these are the pros and cons of each. So yeah, which is, again, I think I probably say something to that effect during most presentations, but I think, when we're thinking about screening, when we're thinking about that point of contact, when we might be asking these questions, we need patients to feel comfortable, and we need to keep ourselves in check as we kind of move forward with a positive screen or a negative screen. So yeah. All right. Well, that was all I've got for today. We'll plan to see you at the next one.